Hey guys, this is Yasser again from Preparing from the Usmle. That's my channel. So subscribe whenever you can. Hit the subscribe button and let's start our journey to the Usmle step one. So today we're gonna continue with the questions that we have for U World and the USMLE. So let's hit it. A 50-year-old woman comes to the emergency department due to fever and abdominal pain. The patient has a history of type 2 diabetes mellitus. Her temperature is 38.3 degrees Celsius. Abdominal examination is notable for right upper quadrant tenderness to palpation. Right upper quadrant tenderness to palpation that is worsened by deep inspiration. Laboratory studies show leukocytosis. Ultrasound abdomen reveals multiple gallstones and gallbladder wall thickening with pericholecystic fluid. Blood cultures are drawn and surgical consultation is required. The patient is initiated on intravenous piperacillin combined with tazobactam. Piperacillin combined with tazobactam. Which of the following is the most likely reason to use this drug combination in this patient? The answer is decreased bacterial inactivation of piperacillin. Decreased bacterial inactivation of piperacillin. These patients' fever, leukocytosis, right upper quadrant pain with positive Murphy sign, and ultrasound findings, gallstones, wall thickening, pericholecystic fluid, indicate acute cholecystitis. Indicate acute cholecystitis. Antibiotic therapy is often administered to prevent secondary infection. Escherichia coli, Klebsiella, due to biliary ectasis, particularly in patients who have diabetes mellitus or immunodeficiencies. Antibiotic therapy is often administered to prevent secondary infection. Escherichia coli, Klebsiella due to biliary ectasis, particularly in patients who have diabetes mellitus or immunodeficiency. particularly in patients who have diabetes mellitus or immunodeficiency. The penicillin family of antibiotics, piperacillin, contains a beta-lactam ring, which inhibits peptidoglycan cross-linking and causes bacterial cell wall disruptions. Piperacillin is a beta-lactam ring, which inhibits peptidoglycan cross-linking and causes bacterial cell wall disruption. Persistence is often due to beta-lactamase, a bacterial enzyme that hydrolyzes and inactivates the beta-lactam ring. The co-administration of beta-lactamase inhibitors such as tazobactam prevents the beta-lactamase producing organisms from inactivating penicillins, which extends their spectrum of activity, broadens, in other terms, broadens the range of microbes that can be treated. That's good. Some penicillin derivatives antibiotics, late generation cephalosporins, carbamazepines, have beta-lactam rings with additional chemical components which make them partially or completely resistant to beta-lactamases. Beta-lactam rings. Beta-lactam rings with additional chemical components which make them partially or incompletely resistant to beta-lactamases. Probenecid, a uricosuric agent used for hyperuricemia with gout, blocks the tubular excretion of penicillins and cephalosporins, and is sometimes used to increase their serum level or prolong their half-life. Uricosuric agent used for hyperuricemia with gout blocks the renal tubular excretion of penicillins and cephalosporins, and is sometimes used to increase their serum level or prolong their half-life. Aminoglycosides inhibit bacterial protein synthesis by blocking 30S ribosomal subunit. Penicillins are often co-administered with aminoglycosides to aid in their entry into the cell. Penicillins disrupt the cell wall, which allow aminoglycosides to penetrate the bacteria. Penicillins are often co-administered with aminoglycosides to aid in their entry into the cell. Penicillins disrupt the cell wall, which allow aminoglycosides to penetrate the bacteria. Okay, so they are additive. Piperacillin is always administered intravenously, so bioavailability is 100%. Tazobactam inhibits beta-lactamase. It does not alter piperacillin metabolism or excretion. Additive antimicrobial activity occurs when two different antibiotics classes are used in combination, such as fluoroquinolone, DNA gyrase inhibitor, with vancomycin, so wall synthesis inhibitor. Beta-lactamase inhibitors block the enzyme that destroys penicillins. They do not independently provide antimicrobial activity, so they are always used in combination with penicillin class agents. Educational objective: beta-lactamase inhibitors, clavulanic acid, sulbactam, tazobactam prevent beta-lactamase from inactivating penicillin class drugs, which extends the spectrum of their activity. A 40-year-old man hospitalized for acute cholecystitis is being evaluated for anxiety and agitation. He underwent an open cholecystectomy without having any operative complications. 2 days after admission, the patient experiences anxiety and tremulousness. Anxiety and tremulousness. And he becomes irritable, severely agitated, and verbally abusive to the nursing staff. He has none of the medical problems. The patient does not use tobacco or illicit drugs, but admits to drinking 6 to 8 beers daily for the last several years. He has no unknown drugs allergies, and the family history is insignificant. Blood pressure is 160 over 90 millimeters of mercury, and pulse is 110. Examination shows hand tremors bilaterally. Which of the following is the most appropriate pharmacotherapy for this patient? These patients' acute onset of tremulousness, agitation, and elevated pulse and blood pressure within 48 hours of admission is suggestive of alcohol withdrawal. These patients acute onset of tremulousness, agitation, and elevated pulse and blood pressure within 48 hours of admission is suggestive of alcohol withdrawal. Chlordiazepine oxide. Alcohol is a CNS depressant that binds the GABA-A receptor complex and hastens the inhibitory action of GABA, the major inhibitory neurotransmitter in the brain. Alcohol is a CNS depressant that binds to the GABA-A receptor complex, enhancing the inhibitory action of GABA, the major inhibitory neurotransmitter in the brain. A broad cessation of alcohol decreases the inhibitory tone and results in CNS excitation. Alcohol withdrawal symptoms typically start within 8 to 12 hours after the last drink and include insomnia, tremolousness, anxiety, and autonomic hyperactivity. 8 to 12 hours after the last drink include insomnia, tremolousness, anxiety, and autonomic hyperactivity, variable blood pressure, diaphoresis, and tachycardia. Alcohol withdrawal seizures can occur within 12 to 48 hours. In delirium tremens, disorientation, severe agitation, fever typically begins 48 hours. So, withdrawal after the last drink is with insomnia, tremolousness, anxiety, and autonomic hyperactivity, variable blood pressure, diaphoresis, and tachycardia. Alcohol withdrawal seizures can occur within 12 to 48 hours. In delirium tremens, the disorientation, severe agitation, fear typically begins 48 to 96 hours. Delirium tremens. 8 to 12, 12 to 48, 48 to 96. Alcohol barbiturates and benzodiazepines have similar effects on GABA receptors and act by enhancing GABA inhibitory action. Alcohol barbiturates, benzodiazepines have similar effects on GABA receptors and act by enhancing GABA inhibitory action. Benzodiazepines, lorazepam, alcohol barbiturates, and benzodiazepine have similar effects and enhancing GABA inhibitory action. Benzodiazepines like lorazepam, diazepam, chlordiazepoxide are used as first-line therapy for psychomotor agitation associated with alcohol withdrawal and to prevent progression to seizures and delirium. Longer-acting benzodiazepines and those with active metabolites are preferred in the majority of patients due to self-tapering effects, resulting in smoother course withdrawal. Baclofen is an antagonist of GABA-B receptors and is used to treat specific conditions. It is less effective than benzodiazepines for treating alcohol withdrawal. Baclofen is an agonist of GABA-B receptors, so it stimulates the receptors and is used to treat specific conditions. It is less effective than benzodiazepines for treating alcohol withdrawal. Carbamazepine may have a role in outpatient management of mild alcohol withdrawal, but there is insufficient evidence for its use in moderate to severe alcohol withdrawal. diazepam mild alcohol withdrawal. It has no utility in alcohol withdrawal. The other answer, the other explanation is about chlorpromazine and allopurinol are antipsychotic medications that lower the seizure threshold. They lower the seizure threshold. They should not be used to treat alcohol withdrawal as the patients are already at significant risk for seizure. Phenobarbital is a barbiturate anticonvulsant, that enhances GABA activity. It is no longer used as a first-line treatment for alcohol withdrawal because it has a worse safety profile than benzodiazepines. It is not longer used as the first-line treatment for alcohol withdrawal because it has a worse safety profile than benzodiazepines. The beta blocker propranolol can treat tremor, tachycardia, hypertension, but it has not been shown to prevent the development of seizures or delayed tremors. Treatment with benzodiazepines is the most crucial step in management of alcohol withdrawal. Educational objective: alcohol withdrawal should be considered in hospitalized patients who develop tremulousness, agitation, elevated pulse, and blood pressure within 48 hours following admission. Benzodiazepines act as a substitute for the effects of alcohol on GABA receptors, preventing alcohol withdrawal from occurring. Chlordiazepoxide. Seventy-year-old man comes to the office after he was found to have high blood pressure during health fair. The patient denies any medical problems and feels proud that he has not needed to see a doctor for many years. His blood pressure is 170 over 70 millimeters of mercury. Pulse is 74 per minute. Other physical examination findings are normal. The patient is started on a medication to treat his hypertension. During his follow-up 3 visits, 3 weeks later, he reports bilateral leg swelling. He has no chest pain, shortness of breath, or abdominal symptoms. His blood pressure is 135 over 65 and pulse 80 per minute. The pulmonary examination is normal, but there is bilateral symmetrical 2 cross-pitting lower extremity edema. However, shown serum creatinine at 0.8. milligrams per deciliter, and lead analysis is negative for proteinuria. Which of the following was most likely prescribed to treat the patient's hypertension? Amlodipine, Side effects of common antihypertensive medication drugs, thiazide diuretics. Side effects: acute kidney injury, electrolyte disturbances like hyponatremia, hypokalemia, hyperuricemia, and acute gout. Elevated glucose and cholesterol levels. ACE inhibitors, cough, angioedema, hyperkalemia. Calcium channel blockers, amlodipine and nifedipine, peripheral edema, dizziness, or lightheadedness. Lightheadedness. And beta blockers, bronchospasm, bradycardia, fatigue, sexual dysfunction. Dihydropyridine calcium channel blockers like amlodipine, nifedipine are effective antihypertensive agents commonly used as monotherapy or in combination with other agents to treat hypertension. The major side effects associated with use of calcium channel blockers include headache, flushing, dizziness, and peripheral edema. Development of peripheral edema is related to preferential dilation of the precapillary vessels, arteriolar dilation, which leads to increased capillary hydrostatic pressure. And fluid extravasation into the interstitium. Renin-angiotensin system blockers like ACE inhibitors or angiotensin II receptor blockers cause post-capillary venodilation and can normalize the increased inhibitors and can normalize the increased capillary hydrostatic pressure, reducing the risk of peripheral edema in patients taking calcium channel blockers. So renin-angiotensin system blockers like ACE inhibitors or angiotensin II receptor blockers (ARBs) cause post-capillary venodilation and can normalize the increased capillary hydrostatic pressure, reducing the risk of peripheral edema in patients taking calcium channel blockers. Eplerenone is an aldosterone antagonist and functions similarly to spironolactone as a potassium-sparing diuretic. The most frequent side effects of eplerenone are hyperkalemia. Increased creatinine and gynecomastia. %, versus 10% with spironolactone. The most common side effects of thiazide. The most common side effect of thiazide, hydrochlorothiazide, and loop diuretics are electrolyte abnormalities such as hypokalemia, hyponatremia, hypermagnesemia. They do not cause peripheral edema. The potential side effects of ACE inhibitors like ramipril and ARBs, valsartan, include cough, hypotension, hyperkalemia, and angioedema. cough, hypotension, hyperkalemia, and angioedema. The risk of cough and angioedema is much lower with ARBs. These medications do not cause peripheral edema. Amlodipine is a dihydropyridine calcium channel blocker commonly used as monotherapy or in combination with other agents for treatment of hypertension. Major side effects include headache, flushing, dizziness, and peripheral edema. External stimulus applied to the cells increases the activity of several enzymes. Including the hydrofolate reductase and DNA polymerase. Which of the following immediately precedes the observed effect? Retinoblasoma protein phosphorylation. An increase in the activity of enzymes responsible for DNA synthesis signifies that the cell is in the S phase of the cell cycle. The transition from G1 to S phase is one of the primary cell cycle checkpoints that ensure quality control of the DNA. Cells with damaged DNA are not allowed to enter the S phase. Retinoblastoma protein is a regulator of the G1 S phase transition. Retinoblastoma protein is present in one or two forms of active hypophosphorylated or inactive hyperphosphorylated. Active hypophosphorylated or inactive hyperphosphorylated. The resting cells in the G0 phase contain active hypophosphorylated retinoblastoma protein. When the cell is stimulated by growth factor, activation of cyclin D, cyclin E, and corresponding cyclin kinase 4 and 6 occurs, and the retinoblastoma protein is hyperphosphorylated, rendering it inactive. When the cells is stimulated by growth factor, activation of cyclin D, cyclin E, and the corresponding cyclin-dependent kinase, cyclin-dependent kinase 4 and 6 occurs, and the retinoblastoma protein is hyperphosphorylated, rendering it inactive. Hyperphosphorylated retinoblastoma releases E2F transcription factor, which allows the cell to progress through the G1S checkpoint. Hyperphosphorylated retinoblastoma releases E2 factor transcription, E2F transcription factor, which allows the cell to progress through G1 and S checkpoint. It releases an E2F transcription factor, which allows the cell to progress through G1S checkpoint. If the retinoblastoma protein is hypophosphorylated, it means it's active, it binds to the E2F transcription factor. This complex inhibits the transcription of genes necessary for G1 to S transition. Active retinoblastoma protein therefore serves as a brake that stops the cell from dividing. The P27 protein is a cell cycle inhibitor. It acts during G1 phase by inhibiting cyclically dependent kinases. Normal tissue contain high levels of P27, while malignant tissue contain very low levels of P27. During G1 phase by inhibiting cyclically dependent kinase. Kinases. Normal tissues contain high levels of P27, while malignant tissues contain very low levels of P27. Upregulation of P27 would stop the cycle of the cell cycle. Caspases are cysteine proteases. Proteases enzyme essential for apoptosis. Caspases are not associated with G1 to S transition in the cell cycle. Ras protein is a component of MAP kinase signal transduction system. It transmits the stimulus from the receptor to the cell surface into the nucleus. Is a component of the MAP kinase signal transduction system. It transmits the stimulus from the receptor on the cell surface into the nucleus. Then the Ras protein is not associated with G1 S transition in the cell cycle. Protein kinase A is a component of cyclic AMP signaling system. It is not associated with G1 to S transition in the cell cycle. Educational objective. Is a component of the CMP signaling system. It is not associated with G1 to S transition in the cell cycle. Educational objective. Proliferation signals activate cyclic dependent kinase 4. Cyclic dependent kinase 4 resulting in hyperphosphorylation of the retinoblastoma protein. Proliferation signal activates cyclic dependent kinase 4 resulting in hyperphosphorylation of retinoblastoma protein. Because hyperphosphorylated retinoblastoma is inactive, cells are allowed to transition unchecked. Because hyperphosphorylated retinoblastoma is inactive, cells are allowed to transition unchecked because hyperphosphorylated retinoblastoma is inactive. Cells are allowed to transition unchecked from G1 phase to S phase in the cell cycle. 44-year-old woman with history of breast cancer comes to the office due to persistent back pain. The patient was recently started on radiation treatment for several vertebral metastases. She has taken acetaminophen and non-steroidal anti-inflammatory drugs, but continues to have severe pain. On physical examination, she has tenderness over several lumbar vertebrae. Neurologic examination is unremarkable. The patient is started on automorphine therapy. Which of the following is the best, most likely direct effect of this medication on the spinal cord neurons of this patient? The answer is increased potassium efflux out of the cells. So opiate-induced analgesia. Opiates stimulate the mu receptors. The mu receptors blocked the calcium channel receptors. By blocking the calcium channel receptors, calcium influx is blocked. Then what we have is that we're gonna end up with decreased neurotransmitter release. At the same time, opiates stimulate the mu receptors in the postsynaptic neuron. These stimulation of the mu receptors in the postsynaptic neurons will end up blocking the potassium channels, which is an efflux potassium channel, because potassium always has the tendency to go out due to its gradient. Both of these result in decreased neurotransmitter release. Primary neuron, dorsal root ganglia. Secondary neuron. This is a spinal foramina. Okay, let's read this. Morphine is an opiate analgesic that is most commonly used to treat severe chronic pain in patients with cancer. There are three main opiate receptor subtypes: mu, delta, and kappa. That mediate analgesia at the spinal and supraspinal levels. Mediate analgesia at the spinal and supraspinal levels. All of these transmembrane receptors are coupled to inhibitory G proteins. All of the transmembrane receptors are coupled to inhibitory proteins. Morphine and other commonly used opiates have an especially high affinity for the mu receptor, which exerts the strongest analgesic effects. Morphine and other commonly used opiates have a special high affinity for the mu receptors, which exerts the strongest analgesic effects. In the spine, in the spinal canal, in the spine, opiates bind to the mu receptors on the primary efferent neuron, to the mu receptors in the primary efferent neuron, resulting in closure of voltage-gated calcium channels, reducing calcium influx, and decrease excitatory neurotransmitter release, acetylcholine, norepinephrine, serotonin, glutamate, substance P from the presynaptic terminal. In the spine, opiates bind to the mu receptors on the primary afferent neuron, resulting in closure of voltage-gated calcium channels, which reduces the calcium influx and decreases excitatory neurotransmitter release. These excitatory neurotransmitter release are acetylcholine, norepinephrine, serotonin, glutamate, and substance P, which mediates pain. From the presynaptic terminal, opiates also bind to mu receptors on the postsynaptic membrane, which opens potassium channels and leads to membrane hyperpolarization due to potassium efflux. Opiate-induced inhibition of synaptic activity in the central nervous system attenuates the pain transmission, producing analgesia. Digoxin is a cardiac glycoside that enables sodium-potassium ATPase pump in myocardial cells, resulting in mild increase in intracellular sodium and direct inhibition of sodium-calcium exchanger. Digoxin is a cardiac glycoside that enables sodium-potassium ATPase pump in myocardial cells, resulting in mild increase in intracellular sodium and direct inhibition of sodium-calcium exchanger. Digoxin is a cardiac glycoside that enables the sodium-potassium ATPase pump in the myocardial cells, resulting in a mild increase in intracellular sodium and indirect inhibition of the sodium-calcium exchanger. Digoxin is a cardiac glycoside that enables sodium-potassium ATPase pump in the myocardial cells, resulting in a mild increase in intracellular sodium and indirect inhibition of the sodium-calcium exchanger. This leads to increased intracellular calcium and cardiac contractility, which can help reduce symptoms in patients with advanced systolic heart failure. Local anesthetics like lidocaine reduce pain transmission by blocking voltage-dependent sodium channels, which decreases the sodium influx and action potential propagation. They are typically used for minor surgical procedures and spinal anesthesia. Benzodiazepines are sedative and hypnotics that may be indicated for anxiety, panic attacks, and insomnia. They work by increasing chloride efflux at GABA-A receptors in the thalamus. Increasing chloride influx at GABA-A receptors in the thalamus, limbic structures, and cerebral cortex. Opiates and analgesics reduce pain by inhibiting the mu receptors and inhibiting the synaptic activity of the central nervous system. Activation of presynaptic mu receptors on the primary afferent neuron leads to closure of the voltage gated calcium channels and reduce excitatory neurotransmitter release. Activation of presynaptic neural receptors on the primary afferent neuron leads to closure of the voltage gated calcium channels and reduce excitatory neurotransmitter release. Binding to the neural receptor of the postsynaptic membrane causes opening of the potassium channels and membrane hyperpolarization. This was great. This was great. Okay, so now when you finish doing the questions, you go back to the first aid and you start hitting the first aid, reading the first aid, and analyzing the data that you just saw, in the UWorld application. Let's break for around 5 minutes, and we're gonna still keep here. So I won't cut the video. I'm just gonna take a rest just to drink some water and refresh my throat, and then let's go back to the study. Okay, 5 minutes. So hi guys, we're back and let's hit these questions again. So this time we're going to the Pathoma book. In the Pathoma book, we're gonna find different chapters, which are the very essential for Usmle step 1. Okay. Let's go. We are in the chapter of homeostasis. Let's hit it. Thrombosis. Hypercoagulable states. Okay, blood transfusion therapy impact red blood cells, dosage, increase hemoglobin and also O2 carrying capacity. O2 carrying capacity. In clinical use in acute blood loss, severe anemia, platelets increase platelet counts. Increase more than 5,000 cells per milliliter cubic per unit. Stop significant bleeding, thrombocytopenia, qualitative platelet disorder defects. Fresh frozen plasma increases coagulation factor levels. Fresh frozen plasma prothrombin complex concentrate. Fresh frozen plasma contains all coagulation factors and plasma proteins. Prothrombin complex concentrate generally contains factor 2, 7, 9, and 10. Okay, prothrombin complex concentrate only contains the vitamin K dependent factors, as well as protein C and protein S. In the clinical use of prothrombin complex concentrate and fresh frozen plasma or DIC in disseminated intravascular coagulation, cirrhosis, immediate anticoagulation reversal. Thus they use coagulation reversal. Cryoprecipitate contains fibrinogen, factor 8, factor 12, bone Willebrand factor, and fibronectin. In the clinical use using coagulation factor deficiencies involving fibronectin and factor 13 and factor 8, So blood transfusion risks include infection transmission, which is low. Transfusion reactions, iron overload, may lead to secondary hemochromatosis. Hypocalcemia, citrate is a calcium chelator. In hyperkalemia, red blood cells may lie in all blood units. Okay, guys. So the time has finished. We have reached the 1 hour mark. So now I'm gonna leave you so you can read your books, your notes, and you can analyze them. Compare your notes with the notes in the UWorld, and keep doing this for at least 3 months or maybe 6 months, eventually until you master these classes. Okay, so take care and see you next class. Bye bye.